I've pushed the button. Okay, welcome everyone. Welcome to what is the final webinar in this series. It's number 4 of our ADBN series for this summer. I'm delighted to welcome Dr. Moira Dunsmore. Moira has heroically stayed up quite late to join us because she's in Australia, so it's midnight thereabouts over there. So please be gentle with your questions later. Nothing complicated, folks, okay?
I might not even notice them if I'm still awake at that point, so yeah.
Moira is a lecturer in community chronic care and public health at the University of Sydney. She has significant transdisciplinary experience of nursing, public health, and health and social science. She also has extensive clinical nursing experience in the UK, Australia, and internationally. So she comes with a wealth of experience on this topic, and I'm delighted that she's going to share it with us today. She's an academic in the Faculty of Medicine and Health, and she has both teaching and research roles. In this webinar, Moira is going to present findings from her PhD research, which explores the social meaning and experiences of older adults with dual sensory impairment and their family and carers in Australia. We were chatting a little bit before we began the webinar, and this is an area that Moira and I share a passion about. So I'm really looking forward to this, Moira, because some of the experiences in Australia, I think we can globally learn a great deal from. So I'm delighted to hand over to Moira. Over to you.
Lovely. Thank you, Liz, and thank you everyone for the warm welcome, and particularly to Peter, Liz and Femke for actually inviting me here in the first place. I do have some slides, so I'm going to share my screen and I'll talk through the slides as I go. Some of them are probably a little bit busier than I would have wanted for this, but I'll talk through each of them as we go. Now, obviously, I don't want to talk about my entire thesis while I'm here, so I'm going to focus really quite specifically on the family carer role, which I see as really being quite integral to actually supporting older people with DSI. So let me just fumble about a bit and get my screen up. Can everyone see that okay? Yep.
Yes, working, Moira. We have got some interference a little bit now that it's come up, though. But keep going, and we'll see if that continues.
Okay, that's fine. I'll just minimize this. Oops. Okay, so yep. I'm just going to mention again, Liz, not that I'm reveling in it or anything, but I'm just going to mention that it is midnight here. So please forgive me for any lapses that I make along the way. As Peter and Liz and Femke have mentioned to me, that this is quite a mixed group of both service users and providers, academics and researchers.
Okay. Je suis pas là demain après.
Could I ask?
Au revoir.
There we go.
Au revoir, Hugues.
Oh, we have somebody with chatter in the background. Can I ask you to mute, please? This is Liz.
Muriel, c'est chez vous. Merci.
Oui, pardon.
Thank you.
Oh, good.
Yeah, I think so, Moira. Go ahead.
Okay. but that's fine. So the title of this presentation is An Invisible Disability, Navigating the Enduring State of Dual Sense Impairment in Older Age. And that was the title of my doctoral work. But as I mentioned before, I'm really going to specifically focus on the aspects of family carers that became really quite critical to the whole thesis. So let me just move my slide. So before I go any further, as is tradition here, I would like to acknowledge that I'm presenting this work and study on unceded Gadigal land, home to the Eora people. So I'd like to pay my respects to elders past, present and future, and also to any First Nations people who are joining us here today. And this slide actually shows the Aboriginal flag, and it's coloured with red, black and yellow. And the black symbolises the Aboriginal people, the red represents the earth and the colour of ochre, and that's used in Aboriginal ceremonies. And the circle of yellow actually represents the sun, which is considered to be a renewer, the constant renewer of life, which is quite a nice way of introducing things. So from my point of view, I always find it really interesting to find out how and why people get started in research, and particularly areas of research like DSI in older persons that often goes relatively unrecognised and unacknowledged. That's certainly from an Australian context. So as Liz mentioned, my background's in nursing. I had a fairly broad experience working in acute critical care areas initially, before I had a bit of an epiphany in the early 2000s when I started a postgraduate public health degree. And although I'd always been drawn to the more social aspects of nursing and public health, it wasn't until I started working in Darwin, Australia, and then in Micronesia in Palau, that it gave me this much better understanding of social behaviour, social determinants of health, and really a bit more about how society works at a more macro level. So coming back from Micronesia, I was at a little bit of a loss as to what I was actually going to be doing. So I did end up applying for a job at the university and was very fortunate to find Dr. Julie Schneider. And I joined the Vision Hearing Project then and worked with Julie. And I'll talk about finding a gap in research shortly, but I finally started my thesis in 2016 and just submitted it last year. And so this picture actually shows me, very happy me on my graduation day at Sydney Uni, and it's a nice bound copy of my thesis sitting beside it. But I always feel that people have a personal and a professional narrative that goes alongside their research. And certainly that's the case for me. My little daughter there, who is now 22, was born with a congenital cataract and had significant sensory issues throughout school, and some significant challenges that she had to overcome along the way. And like many other people, I've experienced parents with hearing and vision loss as well, and some of the social aspects of that are very difficult. But I'm pleased to say my daughter, who's 22, is now studying, and a very happy, lovely young lady. So yeah. Anyway, the last thing I want to mention here is that some of the key interests from my nursing and from my public health really focus on how we communicate, care for and interact with older people, and specifically with DSI. So that's from a nursing and an interdisciplinary perspective. And I think to really dig down a bit deeper, we have to really understand the narrative of aging, because ageism and stigmatization is incredibly pervasive in Australia and in many other westernized countries. So what I'm propose to talk about today is really to give you a little bit of the Australian context to DSI. Apologies if there's anyone from Australia here, so it might be a bit tedious, but certainly our prevalence and etiology, etc., are very similar to that of the global picture. I'll then talk a little bit about the study, some of the findings. I'll give you some context round about that, and then I'll dig a little bit deeper into conscious caring and this idea of the effort and art of caring before looking at some of the work that I'm involved in now and where this work's taking me. So a lot of this will not be of any major surprise to you because our global aging population is occurring in Australia too. And we know the prevalence of deafblindness and dual sensory impairment across the lifespan at the global population is roughly about 2%, recognizing, of course, that there are measurement and reporting issues that we acknowledge here. And Australia isn't any different, really. The prevalence estimates actually vary. We've used the Blue Mountain Eye Study data, which was a large population-based study that was completed, I think, in 2015. But it's actually now slightly dated, and it doesn't necessarily capture the diversity or the aging trajectory of the population that we have now. And it's also quite narrowly confined to a fairly affluent area of New South Wales. So some of the data that we've got is taken from the SDAC, which is the Survey of Disability, Ageing and Carers. And this in Australia suggests that approximately 8 in 1,000 over the age of 80 experience dual sensory impairment. So our trajectory is very similar to that of other advanced economies. And similarly to other countries, we generally attribute sensory loss to these common age-related conditions such as macular degeneration, cataract, glaucoma, presbycusis, etc. In terms of the First Nations Indigenous population in Australia, we have very little data collected in this, and there is a real and quite urgent need to have some form of nationally representative data to record DSI in this population. Partly because we do know that vision and hearing impairment occur at almost 2 times the rate of that of non-Indigenous populations. And we also know that they are particularly they experience significant burden with chronic and complex diseases that also occur at a younger age as well. Access to healthcare can be very tricky for First Nations peoples in Australia from a cultural perspective. So there really is a significant proportion of work that needs to be worked in there. Some of the complexities of managing DSI or providing context for DSI in Australia is round about the fact that service provision is difficult. We have a very complicated system here. When I thought the NHS was complicated, but it's nothing on the system out here in Australia. We have public and private systems, and we also have federal funding and state funding. So there, at each point, there are barriers that really limit the ability for us to properly integrate care. In the last 8 years, we've had a national disability insurance scheme that covers the population up to the age of 65 and provides choice in terms of how they manage their care. A little bit about that later on. But after the age of 65, people are automatically pushed into the aged care system, which we know is flawed in many ways. And we also know that that transition between those two services is actually very poorly integrated. And some of you might know that we also had two very recent Royal Commissions, massive government inquiries in Australia, which have really identified some core flaws within each of these systems. And they've recommended over 100 recommendations, certainly for aged care, some of which has been implemented, but really very little yet. So some of the major issues is that those under the age of 65 have the NDIS, and obviously those two systems provide very little support in terms of transitioning between the two. So there is poor recognition, and ageism is pervasive. There are limited rehabilitative options for older people with DSI in the aged care system. And we know that those who are older with DSI have very poor healthcare interactions in terms of quality, with a great deal of difficulty actually trying to navigate the system as well. So we know that there are multiple intersectional issues that affect older people, and this idea of older people with a disability and chronic conditions really sets them apart as being quite vulnerable. Before I talk about the study, and I'm just keeping an eye on my time, I think it's important to mention ageism and stigma and to address that, because ageism in Australia is a significant issue here. And I see it as one of the biggest difficulties in identifying disabilities in older persons, because there is a tendency to normalize disabilities just simply as part of aging. So it limits the capacity of older people to actually access healthcare, and it also almost provides this idea of self-stigmatization as well, where they elect not to access care. There's lots of difficulties in trying to challenge ageism, and it's ingrained in the language that we use and really at all levels of communication and interaction. And if you think at the individual level, ageism is very evident in our day-to-day interactions. So based on stereotypes such as assuming an older person isn't able to use technology, or by their repeated representation in the media as a burden. So this idea of self-ageism, negative self-perceptions, can really influence their health and well-being. So in a DSI context, the lack of representation of DSI within their group and of others like them, having a sort of culture of people with DSI, or even diagnostic clarity in many cases, really continues and perpetuates this exclusion. So stigma associated with age and DSI has impact, but actually so does the lack of diagnosis and acknowledgement that we found in this study. So I've also referenced Fricker here from 2007, and certainly some of the work I'm doing at the moment is looking at this idea of epistemic injustice. And what we have found is that older adults with DSI are considered much less credible, for instance, during healthcare interactions, in day-to-day decision-making, which really isolates and excludes and limits their capacity to make and maintain decisions in older life. So the study. So it's lovely to see Walter here because he was one of my examiners. So it's always a bit daunting, but anyway, I'll do my best here. So the study, it's interesting when we think about the gap, because I think doing the Vision Hearing project with Julie way back at the beginning of my research career, we both understood that quantitative data wasn't really hitting the mark with us. There were a number of studies that had already identified the numbers and the prevalence of people with dual sensory impairment. But really what was missing was stories and qualitative data on the lived experience of people with DSI. And although I originally considered using a sort of mixed method study, I really elected to use purely qualitative methods, which aligned with my ideals of social constructivism, my views of the world, and this concept that everything is influenced by context. So from a methodological point of view, all my research and teaching are underpinned by theories of social justice, and my choice of this grounded theory methodology really reflects this. So grounded theory is a fairly long, immersive process where we analyze the data of the participants. So it's very much qualitative. And the research questions and my main interests really lay in how those with DSI experienced life and interacted socially. So we're really aiming to better understand those social experiences of DSI and how they maintained and adapted their social networks and roles in life. There were some hiccups with the study, obviously. Dual sense impairment, older adults are quite hard to find, even despite their prevalence. We understand that, or we understood that while potential participants identified with their vision loss, they very rarely talked about their hearing loss. Their hearing loss was not seen as a priority. It was a secondary issue. And really, I was struggling at one point to try and find sufficient numbers of participants. That is until I started going to some of the community groups for older people, and we knew some of them had vision impairment. And as soon as I started talking about what the study was looking at, about vision and hearing combined, it was almost like a penny had dropped, and so many people came up to talk to me at the end of these sessions, to the point that was almost overrun with participants. So this idea that the participants didn't connect their vision and hearing loss, and they prioritized one over another. And it also meant that I had the opportunity to meet as well. And that became a secondary part of this study. So we used the criteria of 60 years and above. We measured vision loss. We were partnered with Vision Australia in Australia, and we allowed self-report hearing loss. And that was purely from this point of view that we thought participants would report better on their hearing loss if they were able to respond to questions rather than have it measured. And ultimately, we had 23 participants, 8 of whom were carers. And what I looked at was individual experiences. I then looked at the family carers' experiences, and then I brought it all together and looked at the dyadic experiences. So today, I'm really going to talk principally about I'm really going to talk about the family carers, the 8 family carers. When we were doing the study, just a little bit more about the study first though, we actually chose to do intensive interviews, which were taxing for me as the interviewer, but also for the participants. So we paced them. They were all face-to-face. I was very fortunate that I collected data before COVID, and we worked at the pace of the individual using assistive devices where needed. And those interviews generally lasted about an hour with some short breaks in between. We also put a semi-structured interview table together that really used the principles of social capital theory, because I already had this idea that bonding and bridging and linking capital, which I'll talk about shortly, would have impact there as well. So The findings, as I've mentioned, were identified as the individual experience, the carer experience, and then the shared experience. And just a little bit in brief about what this found in total, but the study analysed interviews of people with DSI and their family carers, if they had one, and then looked at shared experience. So in terms of contextualizing the findings of the carers, I think it's probably important that I talk briefly about the first cohort, the individuals with DSI, because they really experienced some significant issues in terms of living with DSI. So these two sections, the meaning and experience of DSI, followed by the transitions and modifications, were really about how they lived with DSI. And what we found was that the difficulty there was a sense of invisibility. They identified day-to-day challenges that were both physical, social, emotional, and a lot of this was shaped by the lack of diagnostic clarity, the lack of options, and the progressive nature of DSI. So there was this clear lack of understanding and recognition that DSI was really anything other than a part of aging, and participants and their social networks generally chose to ignore the combined effects and prioritize one effect, one sensory loss over another. Older adults, again, generally didn't consider DSI to be a disability as such, and in fact didn't like calling it a disability. They would refer to it as vision and hearing loss or an impairment, but they didn't identify that as being a disability. And I think the language means a lot. And they were keen really to prioritize and talk more about their biomedical issues, such as their diabetes, rather than their communication issues. And this was reinforced within primary care in Australia, because there is a distinct lack of accommodation for their communication needs. And I mentioned earlier on, similar to many other countries, our system is under quite a bit of strain at the moment. So actually trying to see a GP, have a session that's long enough to provide adequate communication, are all major challenges for older people. So in a sense, there are barriers to actually seeking care or rehabilitation at primary care level. And certainly the participants that we spoke to with dual sensory impairment also identified the fact that they didn't feel recognised, they didn't feel heard during the primary care consultations, and that it was more often than not their family carer who was involved in the discussion. So although it was designed as a three-way loop, it certainly didn't appear that to those with DSI. So they felt excluded during these consultations. They also talked about the significant social effort and reduced participation that they experienced. And in part, that was because they felt embarrassed. They couldn't join the conversation. They didn't want to go out. They didn't want to participate. And so they were happier disengaging. But that also occurred at the dyad level. So between the care receiver and the caregiver, and there was certainly relational tension that we noticed and that they described to us because of the fractured conversations and the lack of meaningful conversations there too. Some participants with DSI, depending on age, obviously, and also other complex chronic issues that they were experiencing, talked about what we've described as bonds and bridges. And these bonds and bridges relate very much to the immediate family structures that they had round about them, and also the bridges that we see as being having capacity to link older people with DSI to their local communities. They also talked about feeling as though they were in a threatened state, this idea that they didn't feel that they were able to make decisions for themselves in terms of aging in place or having support networks built for them round about their home. So I'll talk more at another time about the enduring state because I really want to move on to the carers. But the meaning and experience, the lack of visibility and the work of DSI and the social effort really compounded much of the physical and navigational issues that they experienced. Now, apologies, this is a little bit of a busy slide, but I'll break it down a little bit. So this theme was titled The Effort and Art of Caring. And that was principally because there was significant effort in caring for someone with DSI, but there was also a lack of visibility because it wasn't seen as a disability, it wasn't acknowledged as a disability. So from the carer's perspective, they didn't get any of the public recognition of being a carer for someone with dementia, for instance. So there was significant effort on a day-to-day basis in being the eyes and ears for someone else. But there was also, when I talk about the art of caring shortly, there's also this idea that there are very specific skills needed in a DSI context and which are really generally quite absent in more formalized care support structures in Australia. So in Australia, family carers make up a huge proportion of the health and social community workforce and actually bridge that gap between the home and residential aged care. So they are seen as critical to meeting these general popular preferences for aging in place. But their care is often generally unrecognised. In terms of the formal carers that we found, they tended to be transactional, very task orientated, and not specifically aware of the communication needs of people they were looking after with DSI. And it was most of the time up to the carer to actually identify some of the communication issues and to relate that to carers who were coming in a regular basis. So in terms of, where am I? Sorry. So the diagram that you see here actually shows a very neat diagram of what was a very messy analytical process, which came up with this overarching theme, but actually covered key areas like social isolation, social effort, how they negotiated relationships, both at a dyad level, but also more importantly, more broadly, how they reimagined care in a DSI context, and then conscious caring. So I'm going to talk briefly about each of those. And this slide shows the effort of caring and this idea that the significant social effort that carers went to actually created issues for them as well. We did find that many of the issues that those with DSI experienced also were experienced by family carers. So the idea of social effort, of missing opportunities to be social as an individual, as an autonomous person in their own right, were really lost. And there was significant social discomfort relayed between the dyad during social outings. I've got a number of quotes I'll talk about later, but the social discomfort was in trying to engage and trying to break into the conversation and trying to actually understand what was being said from multiple different sources. So what we found was that social networks contracted right the way down. And normally during aging, that process does happen, but this was particularly contracted because of the effort of trying to engage. much of the social isolation that they experienced were really shaped by the lack of options and the lack of visibility that they had. There was this clear lack of recognition that DSI was anything other than part of aging. And because older adults themselves didn't actually consider it to be something worth doing something about, it causes a great deal of interpersonal tension as well. So there was this tendency to reduce, isolate, and remain invisible and participate in a more passive way rather than they were. And for the carers, this was significant because it was seen as really putting their life on hold, particularly for some of the daughter carers that we interviewed who had difficulty accessing health care, formalized health care because the disabilities weren't necessarily recognized, and some of the home care setup, home care packages weren't necessarily appropriate or safe in terms of leaving their family member with them. So I mentioned social capital before in terms of how this sort of played out in this thesis. And we know obviously that there's a strong connection between healthy social relations and emotional and physical health across the lifespan. And both the WHO and UNCRPD consider social support networks to be a key determinant of health. And the recent WHO report on integrated care for older people really advocates interdisciplinary action in managing loneliness and social participation as a way of improving quality of life and managing decline. So we know social networks are protective in all age groups, and they're really important when it comes to aging. So for older adults, disengagement and social isolation are key concerns. So DSI obviously interrupts communication pathways, conversations are interrupted and misinterpreted, and socializing becomes a significant issue. But we noticed that also this concept of being able to reciprocate and in terms of managing their social relationships was also lost. They didn't feel that they wanted to engage with other people because they couldn't invite them back in, or they couldn't engage in other ways with them. One of the key issues that we found in the study was the poor quality of healthcare communication and healthcare interactions. And I've mentioned the complexity of the Australian healthcare system, but also there are other significant issues in terms of primary care visits, which are short, they're costly. There's very few bulk billing GPs, which means that people have to pay to visit a GP now. Many of the participants felt that they lost agency because their real needs weren't actually being met. And many of them talked about interactions with primary care where they would talk about all the biomedical issues, the fixable things, but really didn't address any of those vision and hearing issues. So it became an elephant in the room. And GPs in Australia act very much as gatekeepers. So in terms of referring on to appropriate rehabilitation or aged care, often it wasn't seen as a priority. So communication really is central to building a relationship with a GP. They tended to develop a more passive relationship with their healthcare provider where they lacked agency and the family carer took over. So it meant that family carers were absolutely integral to any healthcare communication. And it also meant that some of the information about their healthcare needs was also lost. And we know from previous work that there is a mismatch between those that are seeking help from their GP and DSI or hearing impairment, and those that actually receive help or referral. And some of the reason, and we haven't actually explored this with GPs, but some of the information really goes back to the lack of rehabilitative options in Australia for older people with DSI. So in terms of how we think about care in a DSI context, interviewing the carers was really informative in terms of how they adapted and renegotiated a new role. But that was often fraught for some of them because of this, the lack of external support. They'd isolated themselves, they'd lost some of their social networks, and there was this real lack of recognition or empathy for their role. We found that carers, as well as the individual with DSI, actually tended to minimize the DSI because they weren't fully deaf or fully blind. They tended to say, well, you could do a bit more, you could try and do this. But that whole spiral of disengagement, of social loss, of depression in many cases, really had an impact on both the individual with DSI and their family carer. And often there was a tendency to just dismiss issues that were too complex to understand or fix. So for carers, there was this idea of active and passive transition to the role of carer. And for some, it felt like this was a progressive, enduring state where they felt stuck and they were really only there for because of a sense of duty. So the art of caring gives us a little bit more hope, because so far I've described the carer's role as being quite arduous, as being socially isolating and challenging. But what was really clear in some of the carers' narratives was that with support, whether it was formal or informal, and better understanding and education about DSI, carers were in fact very able to develop some key skills that improved their quality of life, but also that of their partner or parent. So this final theme really helps position carers really as key to improvements in this space. So conscious caring, this idea of a model of conscious caring really represents a bridging link between these microsocial issues that were going on at the dyad level and linking that with our broader social networks, because that really is the route to improving social engagement, or actually personalizing social engagement. I think we're always very keen to improve or think about social engagement as being quantity rather than quality. For our participants, what they really wanted was better quality social engagement with smaller networks. So that might mean their family, their immediate friends, rather than large group settings or community groups. Conscious caring was also about supporting family carers to receive support for themselves in order to actively transition into this role. And that really does need a little bit of work. But the three key aspects of a conscious caring model is about social facilitation and protection. So destigmatizing DSI for others, increasing the visibility of that, and engagement in social networks. And one of the ways of doing that is integrating formal and informal care networks. It also depends on available support and creating opportunities to retain independence. So that idea of empathy and empathic understanding of what's going on for someone with DSI is really important. And that in our dyad wasn't clear that the carers actually always understood what was going on. And in terms of enabling a safe space, I think it's really important that we enable sustainable and safe links to social events that are appropriate for them and increase independence for both. In terms of some of the, I think it's always important when we're talking about lived experience to actually include what some of the participants have actually said and how we've analysed some of this data. But this was a very active couple who Gail was a carer for Clive. Clive was in his 90s. Gail was a little bit younger, and they'd been very actively social all their life, but they gradually disengaged. They didn't understand what was going on. People turned away from them. So Clive can hold his own. It's just that sometimes in a group situation, people tend to have a conversation. They don't have, they have eye contact and they don't use names. You actually just have eye contact. So if I'm speaking to you, I don't necessarily have to use your name because I'm speaking to you, but Clive doesn't. He sits there and someone's trying to say something to him, and when they don't get a response, they turn away. Others, yeah, I absolutely like to go out with my daughters because they do all the conversing and I sit back and enjoy it. So this idea of passive social participation. Oops, better move. Oops. Sorry, we can't actually see that last one, but this really relates to this idea of the interactions that occur on a day-to-day basis, the interactions at the checkout, interactions within the supermarket, interactions with neighbours that are essentially lost for someone with DSI if they're not able to engage externally. And I think this final quote really sums up the difficulties we experience here with primary care, because there's this idea that there's another thing about the GP, the sort of mentality, well, what do you expect? You're 95. These days, we're all harping on about people with disabilities and how they have to be accommodated, but hearing and vision loss in old age is not seen as a disability, it's just seen as something else. And that was Sarah, one of the carers to her mother, who had significant vision and hearing loss. So what happens now? So I've got all this data, I've done all this work, and I'm constantly reflecting on how far we've actually come in DSI research. Liz and I were talking about this earlier on. So when I started my PhD in 2016, when I was on the Vision Hearing project, there was such a dearth of literature on DSI, and particularly in older people, which does reflect some of the ageist attitudes I talked about at the beginning. So it's good to recognize this and actually see, although it sounds as though it's a little bit doom and gloom for our participants, we can actually, hearing their stories actually gives us information to be able to work on targeted support for them. And I think it's really good to recognize how far we've come and to think about DSI very much from this intersectional perspective as part of aging, as part of disability, and as part of this complex care spectrum, as well as positioning DSI as part of the bigger picture of person-centred older care and reframing the narrative of older care. So where I see the work advancing here is very much in the integration of care between primary care and systems, and ensuring that there is comprehensive social care support to operationalise the work with family carers and to those living at home. And to do this, we need much better embedded education for healthcare professionals, better integration of care networks, education on the development of social haptics for older care, whether that's at home or in residential aged care, and a focus on getting DSI recognised in Australia as a unique disability for older people. And what we've started doing, so some of you may know I've been working with Anne-Marie Watherow on some different aspects. So we've been working on developing micro-credentialing for interdisciplinary health students so that they actually start to understand some of the complexities around that. And some of the vignettes that Anne-Marie has produced has been invaluable in really driving home some of those messages. We also have to, I've got a small seed funding finally to actually start developing some partnerships with New South Wales Carers Association. So looking at trying to integrate care networks better and to educate carers. So that we actually are successful in minimising and preventing risk at primary care and hospital intervention and keeping them safe in hospital. But I think overall, it's really very much about making care personalised so that they are able to make decisions for themselves, that there is this idea of shared decision making really enshrined in how we care for older people. And I think to do that, we really have to tackle ageism head on in Australia from the ground up, from our healthcare students all the way up, because that is one of the key things that really is limiting this idea of improving care and improving the aged care system for older people in Australia. So that's really everything from me. So I'm going to stop sharing. Sorry, I feel like I'm winding down a little bit. I've just looked at the time, and I don't think I've been up this late since I was about 30. So apologies if I was getting slower and slower there, but I'm very happy to take any questions if there are any.
Moira, thank you so much. You were not getting slower and slower. In fact, you held my attention throughout. And thank you very much for a very fascinating presentation. Thank you. As Moira said, if people have questions, do you want to pop your hand up, or either virtually or in real life? Either will work, provided we can see you, and we'll invite people to speak. I can see my co-chair Femke Krieger in the Netherlands is waving her hand. Go for it, Femke.
Yeah, but I will wait if you see others, so it's not like.
No, go for it, Femke.
Yeah. Okay.
Yeah.
Thank you so much. Let's start with that. It felt like such a rich story. There's so much in it, so many topics, so many. It's like, it feels for me like a whole mapping, you know, of a right fast world. And you mentioned so many thresholds, and I recognize them all from lived experience, from research. You mentioned language, you mentioned perception, lack of perception, you mentioned awareness. And at some point you mentioned like it was an elephant in the room.
Yes.
And I combined it with, you know, where you started with that it's, in a way, it's invisible. So I was thinking, okay, this is fun, an invisible elephant in the room. That's something to deal with.
Yeah.
So I really loved it, and I wrote down so much. And to me, key things you mentioned was integration of care, agency, and then that combined with all these topics which hold thresholds and limitations in itself. So there were two things I want just to share and to ask your idea about, your view on. The one thing is this richness comes with very strong conclusions, and I can understand them, but the road towards the conclusions is already so valuable, I think. So wouldn't it be beautiful if you also kind of roadmap the way toward the conclusions, because this is part of the awareness process that is also necessary, as I heard you saying, but I recognize it in the Netherlands, it's completely the same. So even that people kind of like seeing the steps and then see, oh gosh, step 3, there's work to do there, you know, and then, because if you go to the conclusions, there is so much richness that you leave that is also necessary for people to want to be educated. You need some urgency or curiosity, one of both at least, to take the step to get educated. And I think you have so much information inside your study, and I realize we only heard a little about it, to get people feel the urgency or the curiosity. So let's stick to that. Well, that was the one idea. The other thing, in a way, and probably it's me, but what I was missing, and that's because that is my passion, it's the gap between the different sensory experiences. When you are deafblind, like I am, you have a completely different way of sensing the world. So even besides all the things you mentioned, there is this huge different perception of the world that also has huge implications. So this was something like, how is that part of your PhD study, and etc. So 2 big ideas, and I love listening to you about it.
Thank you. In terms of the roadmap, you know, I actually get what you're saying, because I don't want that data lost. I think the stories are the most fascinating part. And yes, the analysis, you know, was quite torturous at sometimes, because it was like being stuck in a mire, trying to work your way out. What are they trying to say? What is linking with other participants? What are the key themes that are coming out? I do think that we are beginning to get a little bit more traction. Certainly for nursing and public health students, we are talking more about this idea of communication. So I think nurses traditionally have been quite good at communicating in terms of risk communication and healthcare communication, but we don't have enough experience with people with communication difficulties in Australia and in the curriculum to be able to enable students to go out with confidence. I mean, part of me feels that the system needs a complete overhaul, but you know, I alone obviously can't do that, but yeah, aged care is a significant problem. Sorry, I'm losing my train of thought there, but yeah, it's a great idea, and I think this idea that students actually work with carers and actually understand, or work with individuals with dual sensory impairment to understand all the nuances is really important. So I don't think I answered that very well.
No, but it's just a start, and that's what the webinars are for, to start a discussion. So thank you so much for that. Yeah.
We have 2 hands up. We have Renu first, and then Helen. So if we can go to Renu.
Thank you.
Renu, be kind. It's late.
Oh, yes. Okay. Thank you. No, I just want to say thank you so much for sharing your study. This is really bringing different perspectives and thoughts. And I agree with you. One of the points where you talked about preventing and minimizing risks in primary care and hospital care, I think that that's really key. And my thought is from the perspective where, you know, here in Canada, the Statistics Canada came out with a study or analysis of the Canadian Survey on Disability data that talked about the age of onset to the age of limitation. You know, onset happens much more earlier for vision and hearing both, and people live with the glasses and hearing aids for longer until they just hit one roadblock, like, okay, this is starting to limit the functionality and the networks. It's affecting the social networks and affecting their engagement, communication and everything. So why wait till then? Why not start this little earlier? Right. This is what my point is, that I don't know in Australia, but in Canada also is the same situation. GPs will just deal with all the, the complex diabetes or other issues. And this will be a white elephant in the room that, oh, I'm having hearing. I just went to my doctor and I said, I feel ringing in my ears. She says, that's not a big issue. You have diabetes. So let's talk about that. And I said, when am I going to get referral to get the hearing tested?
Yeah.
Why am I feeling those ringing in my ears? But that was kind of, I would, sorry to say, it just was not heard.
Yeah.
She didn't pay much attention to my request for that. So,
Yeah.
so
But I completely agree. I think this idea, I did quite a lot of work in the study about GPs as gatekeepers, and this idea that they are really responsible for the direction that a client takes. So that those were significant issues, and there's a lot of hierarchy within Australia. I don't know what the Canadian system's like, but the GP, certainly for our older participants, was really seen very much as the god and the holder of all knowledge. So they didn't push on issues. They didn't, they tended to passively accept what was happening within the system. And I think it also fed into this idea that if the GP doesn't recognize my dual sensory impairment, then why should I? You know, it's obviously not a big issue because I'm old. And they were told, you know, it's part of aging. It might be, but it's still an impairment that needs to be addressed. When patients when they go into hospital, we're not getting proper informed consent if we're unable to communicate with them. And, you know, certainly there's been huge documentation of some of the adverse events that have gone on in hospital itself. So, yeah, so the GP as gatekeeper is a big issue, but I think the setup, the system and the structures that surround that are very limiting as well, because we have, limited access to GPs at the moment and very short periods. And telehealth was just rubbish for people with dual sensory impairment. It just didn't work. So it was the family carers, again, that were having to step into that role. So individuals with DSI lose agency because they're giving it over to their family carer.
Same situation here in Canada.
Yeah. So thank you.
I can see lots of nodding heads with those comments, Moira. I could see my colleague down in Kent, Stephanie was nodding away, and Helen was nodding away as well. I think what's interesting for me is that these experiences, they're not unique to Australia or the UK or the Netherlands. There's a fundamental issue there about older people, the aging process, and dual sensory loss. And it's been there for as long as I've been in the sector, which is over 30 years.
Yeah,
we're getting there, but it's much too slow, I think, is the honest answer. Anyway, not my turn to speak. Helen, over to you.
Thank you so much, Liz.
Hi, Helen.
And many thanks to Peter as well for inviting me to this wonderful webinar. Yeah, my name is Helen. I'm in Zambia. I'm a parent of a child that was born with congenital deaf blindness. So I advocate so much on congenital deaf blindness, and I represent parents of deaf-blind children here in Zambia. So listening to this presentation on dual sensory impairments, I've learned quite a lot of things, and I picked on awareness. So it's like back here in Africa, we need a lot of awareness on that, because I've seen we do not even have statistics that shows people that are living with dual sensory impairment. Even when it comes to congenital deaf-blind children that we have in Zambia, we still do not have statistics. Thank you very much. So I think I've learned that I will have to share this information to my other colleagues so that we can do more awareness on dual sensory impairment, so that we can save our old people that are living with dual sensory impairment, because I've seen most of them are also identified wrongly. People don't understand that they are old people with dual sensory impairment. They even label them as, like maybe they're mad people. And, in here in Africa,
decline.
as where they can even relate it to witchcraft. So, like for me, I think awareness is important to me. I think I'll have to work much on that. Otherwise, it has been a very good presentation. and good to see everyone who's here in the webinar. Thank you.
Thank you very much, Helen. Lovely to meet you.
Thanks, Helen. Thanks for sharing that. That's a salutary lesson to us, I think, as well. But that key word is in there, awareness. Yeah, and it goes right across the age spectrum. Yeah, thank you.
Yep,
Stephanie, you have a question.
Hello, everyone. Yeah, I'm so sorry I came in late. I've actually got somebody in hospital at the moment who's deafblind, and it's a very difficult situation. So yeah, I've been on the phone, so I couldn't make it earlier. I see it's being recorded. Is there a chance for me to catch up on this? Yeah.
Yes.
Okay, that's great.
It's available. All of our webinars are available for a short period of time after the webinar. So yes, you can catch up. And
Brilliant.
Peter, once Peter is back, Peter will email you a link to the webinar, so you'll get a summary and a link to the webinar. Yeah,
right.
And that please other members of the network do share that with people who are members of the network and may have missed today's webinar, that there is the opportunity to watch it again, only if you are a member of the network. Please do not share the link outside the network. We don't have permission from our speakers to do that. They give us exclusive permission, and that's why we ask that you keep it within the network. But yes, please do share with those who are. Monica, you.
Thank you. Oh,
Monica,
sorry.
Just
question in the.
Sorry, Liz, but to add, if you think people are interested, make them a member.
Yes.
Because it's completely free. So when they are a member, they can share.
Yep.
Good marketing.
They can also, looking down at Carolyn down there, they can also join our Facebook page, can't they, Carolyn? We are trying to use that more and more, so please do have a look at it, do use it. We are trying to build it as a way of exchanging information and a way of the network members of the network staying in contact with each other between webinars and between events, because it's important that we're able to share. The Facebook page, Carolyn and her colleague Greta very kindly manage it on our behalf, but we really need you to take part in it, so please do. Yeah,
I think Stephanie had a question.
Yeah,
go for it, Steph.
Sorry, I just wanted to kind of add, because I obviously really, because it's so relevant at the moment, having somebody in hospital, about this experience of people and the communication, and actually I've just recently registered as an occupational therapist, so I'm thinking around moving and handling as well, and how that's that lack of communication to even let somebody know in a tactile way that you're about to do something, there's a maneuver going to be happening. How scary that is for somebody to not have any clue of what's about to happen, is something that's really struck me, and that I'm thinking now, how could that be incorporated into, like you were saying, with student nurses, how can that be incorporated in the UK here? When I was doing my studies, there was I think it was the Canadian Occupational Therapy body that had done a study on what kind of training that student occupational therapists have around deafblindness as a student, and that was very interesting. Obviously, it's a shame it wasn't also incorporated in other parts of the world, other universities, but
I think there is a and I think there is a big is because it's not the communication is one part of it, but there's also navigating all environments as well, and obviously I'm preaching to the converted here, but that idea of the social space is really important, but without family carer with them in hospital, it makes it very difficult. So for the participants in this study who weren't able to have their family carer with them in hospital, there were some adverse events that happened as a result of that. They weren't able to be there to vocalize what their partner or parent needed, and they weren't able to communicate that. So it's a huge issue, and I feel quite embarrassed to, you know, say that nurses ignore older patients with communication difficulties, and I know the structures are such that everyone is incredibly busy, but communication should be core business, really. You know, understanding a patient is part of what we do. So it is upsetting to hear some of the communication stories that we have. So I was just looking at Monica's comment as well. And I do feel that maybe there is this idea that the ageism that we see in Western countries isn't perhaps as bad, and that maybe, I don't know, in terms of Japan, maybe someone else can comment on what it's like in other countries, but I do find Australia quite ageist in terms of the way we look after our older people, and that was not just during COVID. That's been going on for some time.
Anybody willing to come back on that one? Anybody willing to comment about the experience in their country? No. Okay. I'm very aware of how late it is, Moira, and the fact that we've overrun, which is a good thing. It shows that there's a lot of interest and a lot of questions. I want to say a huge thank you. Firstly, because the presentation was so interesting, stimulating, and ticked all the boxes for many of us. I think there were so many nodding heads looking around, so thank you very much. And the second thank you is because we know this has been a big sacrifice and you will have quite a bit of sleep to make up on, so thank you very much.
It was my pleasure.
Thank you. Thank you to all the members who have attended today. In total, we had 22 of you, which is great. So thank you very much for joining us today for what is the fourth and final webinar in this series. Do keep an eye on AGBN News. We hope to be able to bring you another series of webinars in the future. If you have any suggestions on topic, if you would like to speak, if you have something you would like to share with us, please get in touch with Peter, myself, or Femke. We would love to hear from you. And please do make use of the Facebook page. I know Carolyn has put the address in the chat function. So yeah, do have a look at it and do use it. Thank you very much, everyone.
Bye-bye.
Right. Thanks again. Bye-bye for now.
Bye.
Bye, everyone. Thank you.
Bye. Thank you.
Bye.
Okay. Hey. Well, that went. Oh, let me stop recording. Stop recording. Are you sure you want to stop?